Recent papers have shown that amongst practicing trainee doctors and nurses, there is a lack of knowledge of oxygen therapy devices and their correct use. There are also many false beliefs regarding oxygen therapy, with the result that many patients on general wards are incorrectly treated. The following material describes the main types of device commonly used for delivering oxygen therapy. We hope this will increase the level of knowledge in this important discipline. The presentation is divided into three sections: oxygen therapy devices, how they work and what FiO2 can be achieved; humidification; definitions, indications, precautions, and the possible complications of oxygen therapy. Oxygen therapy devices, how they work and what FiO2 can be achieved. The devices for delivery of oxygen can be divided into two categories depending on whether they deliver a proportion or all of the patient's ventilatory requirement. Low-flow devices, also known as variable performance devices, deliver oxygen at flows lower than the patient's inspiratory requirements, so additional room air is also breathed in. High-flow devices, also known as fixed performance devices, deliver flows that meet the patient's total inspiratory requirements. Looking first at low-flow devices, let's look at the various device options that are available. Nasal cannulae are one of the most common ways of delivering oxygen therapy. A nasal cannula consists of two soft prongs attached to the oxygen supply tubing. The prongs are inserted into the patient's nostrils. The tubing is looped over the patient's ears, and the toggle is adjusted to ensure a good fit. Oxygen flows from the cannula into the patient's nasopharynx, which acts as an anatomic reservoir. Oxygen can be administered at 6 litres per minute or less. Flow rates of 4 litres per minute or less do not need to be humidified. Can be used at very low flow rates with children. Lightweight and generally comfortable. Patients are able to eat, drink and speak. Mouth breathers can benefit from this device. Needs upper airway to be free of obstruction. Are available with different prong shapes. The concentration of oxygen received by the patient will vary as previously mentioned. However, oxygen flows of 1 to 6 litres per minute will deliver up to 44% of oxygen to most adult patients. There are various sizes available for adults, pediatrics and neonates, and a variety of prong shapes are also available to suit varying circumstances. Straight prongs are the original design, and these are still the most frequently used in hospitals. Curved prongs are designed to direct the flow of oxygen posteriorly rather than upward towards the frontal sinuses. Flared prongs have an increased diameter towards the tip. This has the effect of slowing down the gas as it enters the nose, making it more comfortable for the patient. Curved and flared prongs combine the best features of the two options, releasing oxygen more slowly and away from the frontal sinuses. Caution: nasal cannulae are contraindicated in patients with nasal obstruction, for example nasal polyps. Medium concentration face masks provide another option for the delivery of low-flow oxygen therapy. These may be used for concentrations higher than those that can be achieved with nasal cannula, or when the nostrils are unavailable. The concentration of oxygen received by the patient will vary. However, as a guideline, 5 to 8 litres per minute will deliver between 35 to 50% FiO2 to most adult patients. There are a variety of sizes for adults, small adults and children. Some masks have nose clips to improve the mask fit. Designs are available with ear loops, which make it unnecessary to lift the patient's head when fitting. One end of the oxygen tube is attached to the spigot on the mask and the other to the oxygen flow meter. The flow meter is set to give the prescribed oxygen concentration. The mask is then fitted over the patient's nose and mouth, and the elastic tightened to give a secure, comfortable fit. If the mask has a nose clip, it is pinched to provide the best possible fit. Caution: flow must be at least 5 litres per minute to wash CO2 out of the mask and prevent rebreathing. Aspiration of vomitus is more likely when a mask is in place. High concentration masks. Non-rebreathing mask. This mask is usually used when high concentrations of oxygen are required. For example, with the critically ill or unstable patient. The patient breathes from the mask and the inspiratory valve opens so that oxygen is taken from the reservoir bag and the patient does not breathe room air. The patient breathes out through the expiratory valve. As the Eco High Concentration mask has a much improved fit, 2 safety valves are included. These allow the patient to breathe room air if the oxygen supply should fail. In reality, this type of mask delivers up to 80% oxygen with flows between 10 and 15 litres per minute. The fit of the mask and the patient's breathing pattern affect the amount of room air entrained and the oxygen concentration delivered. When using the non-rebreathing mask, first attach the oxygen tubing to the oxygen flow meter and set the flow rate to 15 litres per minute. Occlude the inspiratory valve, being careful not to damage the valve, and allow the reservoir bag to fill. Squeeze the reservoir bag to test the patency of the valve between the reservoir bag and the mask. If the reservoir will not empty, discard the mask, choose another and test again. Place the mask on the patient's face, obtaining as tight a fit as possible. Adjust the oxygen flow rate so that the bag deflates by about 1/3 with each breath. Caution: flows must always be high enough to ensure that the reservoir bag does not empty completely at the end of inspiration. Minimum flow 10 litres per minute. Aspiration of vomitus is more likely when a mask is in place.